Good morning, everybody. I'm back with the case of week. A 24-year-old lady presented with lower backache. Her MRI revealed T2 hypointense lesion in S1 and right ala of the sacrum with anterior epidural soft tissue component causing compression of the traversing nerve roots. The lesion measured 3.8 into 3 into 2 centimeters. Intraoperatively, the neurosurgeons informed that it was a vascular tumor arising from the sacrum going into the abdominal cavity. We received three irregular gray white to gray brown soft to firm tissue pieces, which measured 1.4 into 1 into 0.3 centimeters. We prepared paraffin embedded blocks and HE slides, which revealed presence of a vascular tumor invading the bony trabeculae and infiltrating the marrow spaces. The neoplastic cells were round to oval, some were quite undifferentiated, and these were arranged in diffuse sheets. The nuclei of the neoplastic cells were hypochromatic, and the cytoplasm was moderate to ample, eosinophilic. Some of the cells had plasmacytoid, that is eccentric nuclei, and ample amount of eosinophilic cytoplasm. Nuclear pleomorphism, binucleation, multinucleation, and bizarre forms were present. Increased mitotic activity was noted. The intervening stroma showed increased vascularity. There were areas of hemorrhages and thrombosed blood vessels. Areas of necrosis were also seen. Now, this looked to be quite an undifferentiated tumor on histopathology. We went ahead with immunohistochemistry. We ran panel of multiple antibodies to rule out various lesions. So the carcinoma was ruled out, lymphoma was ruled out, tumor of hemopoietic and neuroendocrine origin was ruled out. Even we ran the markers for germ cell tumors, nerve sheath tumors, glial, even meningioma we did, it was negative. What came positive, we even ruled out markers for plasmacytoma and Ewing sarcoma. What we found that the MIB1 was very high, it was 80%, and we obtained immunoreactivity for vimentin, CD31, CD34 focally, podoplanin and FLI1. Also CD138 LCA was focally positive, CD99 was positive, and desmin was focally expressed. So these, we came to the conclusion that this is an angiosarcoma arising from the S1. Angiosarcomas are rare aggressive subtypes of soft tissue sarcomas, and these have propensity for local recurrence and metastasis. They are generally associated with poor prognosis. Now, the cell of origin is the vascular endothelial cell. So these may potentially develop in any organ. The most common risk factors are chronic lymphedema and history of radiation. It is also associated with familial syndromes such as neurofibromatosis type 1, Maffucci syndrome, bilateral retinoblastomas, and others. It is associated with exposure to vinyl chloride, arsenic, and thorium dioxide. Now, the most commonly affected sites are skin of head and neck. Almost 60% of cases show this localization. Soft tissues, visceral organs, bone, and retroperitoneum. The differential diagnosis on histopathology could be atypical fibroxanthoma, Kaposi sarcoma, retiform hemangioendothelioma, Kaposiform hemangioendothelioma, epithelioid hemangioendothelioma, and spindle cell hemangiomas. Now, immunohistochemistry can help differentiate these entities. The treatment predominantly is surgical. However, chemo and radiotherapy may also be given. And in the newer modalities, targeted therapies and immunotherapies have also been studied. Thank you very much.